This is a series of thoughts in trying to update psychiatry, because you all are psychiatrists. You're practicing it, whether you acknowledge that you're a psychiatrist or not. You all are psychiatrists. There's data that 40% of people come to see their health care worker with a complaint other than the stated complaint. 40% of people are coming in there with something else going on, but how do I get in the front door? I get in the front door with abdominal pain. I don't get in the front door with recurrent obsessive thoughts. That won't get me there. So with that in mind, you're also the prescribers for medication. 70% of people that are treated with psychotropics are treated by you. We were talking at the break, somebody was talking about the inserts that our patients read. They're terrifying. And I'm not sure I want my patients reading the inserts. I maybe even want to get an agreement that I will tell you what the side effects are, but probably don't read the inserts. And if you look at TV in the morning, which I do when I'm on my exercise bike, that's also terrifying. What the ads, and then it's always whispered at the end, it can cause acne or death. And death is always whispered at the end of every one of these. I used to be, and I'm going to see him today. I have a classmate in Charleston. I'm going to go through and see him. When I was in medical school, I had this amazing, I thought, ability to fold a newspaper up into something about that big and read it while the lecture was going on. Dr. Brinkhouse had a picture of all 70 of us, and he would call on us. I was reading my newspaper, sports page, front page. My friend I'm going to see in Charleston punched me and said, "He called on you." I stood up and I didn't say, "Yes, sir." I screamed, "Yes, sir." He was writing on the board. He hadn't called on anybody. My friend who I'm going to see in Charleston said, "Yes." And my friend who I'm going to see in Charleston will tell me again today, which he tells me every time, short of sex, that's the most joy I've taken in this life, watching you stand up and scream, "Yes, sir." I was humiliated. I'm going to summarize STAR-D for you a little bit. This is the best study done about depression in an everyday population. This is a population that was half psychiatrists, half primary care docs, over 14 centers, over several years, really done well. And the highlights are that you treat to remission if you can. It's better to treat somebody to remission of symptoms than, it's better to get to remission, and it's not so good just to get halfway there. If you can, with whatever you use, a HAM-D scale or whatever you use, try to treat to remission. That's the goal. It takes longer than we thought it would. It takes a higher dose than we thought it would, and the results are not very encouraging. We're not doing a good job in psychiatry. We're not doing a good job with the antidepressants. We're not doing a good job with the antipsychotics and the anxiolytics, the anti-anxiety. We're just not. We've got to change the way we're doing it. The antidepressants, we've gone through a couple of ideations, 3. They're really no better. There are less side effects, but they're really no better. The antipsychotics are really no better with a whole new set of side effects. We're just going to have to figure out another way to treat these disorders, and underline that psychotherapy works also. Talking therapy, if we all had the luxury, works also in the hands of somebody that knows what they're doing, not necessarily a psychiatrist, social worker. Lots of people out there know how to do psychotherapy and be in the room with the patient in a cognitive behavioral way. The bad news is, and they started with Celexa, you can start with whatever you want. Get happy with an antidepressant. If you're treating somebody that's really revved up, Remeron's probably a pretty good antidepressant. If you're treating somebody that's really flat, Prozac's probably a pretty good antidepressant. They're all about equal in efficacy. Paxil's an outlier because it got a bad name because of suicidality in a very, very, very poorly done study. It's been cleared, but it's bled into the adult literature. It started in the child literature, and Paxil's kind of black boxed, and the FDA never takes a black box back. I love Paxil. If you've got a patient that's really anxious and depressed, I love Paxil. The algorithm is that after 7 weeks, we won't get but 35% of people treated to remission. And these are everyday patients. They come in with substance problems, with all sorts of problems. This is not a pure study. These are the people we see. We'll get 35% remission. When we go to the second stage, which is to either augment with Wellbutrin or switch antidepressants. And I'd be pretty quick to switch antidepressants if you're not getting somebody well at 7 weeks. Then we go to second stage and we get up to 50% well. If you go the third step, which is the augmenting with thyroid, augmenting with lithium, things I wouldn't be doing, I don't think, although I would on every woman I see get a thyroid panel, at least TSH. Let's just make sure. I don't want to miss that. If you go through the fourth stage, you get 2/3 of people. Remission. Not just better, but remission. And then I would treat for a year, and I begin my conversation with people about SSRIs by saying, I'm going to treat for a year. And then we'll look at where you are. I see a lot of adolescents. I'm not going to take them off medication as they head back to college or have something big going on. I'll try it when we've got a period of time where I can watch them for a couple of months over a summer. And take it down slowly. Get flu-like symptoms. If you don't, you've got to take all these SSRIs down slowly. And your patients that are taking SSRIs one day and not the next, they're getting flu-like symptoms every other day. It makes them feel bad. Better to not take it than to take it that way. Before we leave Star D, I want to say that if you took it through 2 steps and you went to either augmenting with Wellbutrin or switching from your favorite antidepressant to another, and you get to 7 weeks and you're not at remission, if you've got the luxury, I would get some help. I would at least get a consultation from a psychiatrist or somebody that sees these patients. It doesn't have to be 10 times, just one time. I've gotten to this place, my patient's not well, what else do I do? And I can't tell after years in this business now, I can't tell the difference in depression and anxiety. I can give you words and explain them to you, but if I'm anxious long enough, I'm going to get depressed. And if I'm depressed long enough, I'm probably going to get anxious. They very much live together. I'll try to break anxiety down some. We have a group in Chapel Hill called El Futuro, started by a guy from Arkansas, Luke Smith, that is the most Latino-friendly person I guess I know in our area. And he sees Latino patients only, mostly for mental health issues. I asked my faculty to give me some bullets to bring down here, and I suspect a lot of us see Latino patients. He wanted me to tell you this, that particularly first generation, it's hard to engage them in getting help for so many reasons. I think I'm speaking to the choir here. Access, meaning of mental health, stigma. What does it mean to have a mental health problem? He wanted, in helping women particularly, to couch this in helping the family. Understanding spirituality is a huge part of what they bring to the table. His experience, which is massive, is that he can bring more women to the table for treatment for whatever if he couches it in this helping the family. Now, there's an acculturation phenomena. It ain't good for you to live in the United States. The longer you've been here, the more likely you are to get our things. There's a break point at 13 years. People that have lived here that have come from another culture really begin to get all of our stuff. So people that were born in Mexico, for instance, and left a year ago look very different than people that have lived here for 15 years. He wishes me to tell you. If somebody came to me when I was in practice in OB, my most dreaded complaint was, I'm anxious, I'm nervous, because I didn't know what to do with it. I'm better at it, and I might want to talk to patients that I think, and somebody asked me at the break also about an anxious patient, I might want to put it on the table pretty quickly and say, in my experience, you're developing some anxiety, and let's talk about where it comes from. You can break anxiety down into some nice little neat packages. You're left with a big one called generalized anxiety disorder that's hard to treat. But neat little packages about PTSD, something, and we've changed the wording. You don't have to have a horrific event that's life-threatening to have PTSD anymore. Duh. You can be a child in a divorce that's stormy or quiet and get PTSD. There's lots of ways to get PTSD. You're going to have a talk about intimate violence, clearly a way to get PTSD. So there's PTSD, there's panic, which is a whole nother. You have sudden onset of symptoms that last not hours but minutes. And are you now scared that's going to happen again? What drives panic disorder is the fear of another panic attack. I'm told you don't have to have but one to disappear. We had a nurse in Chapel Hill that had a panic attack in the PICU. She went home and was going to retire from nursing. Her minister said, wait a minute, what's going on with you? Has anything happened? She said, yeah, I had a panic attack. That's not going to happen to me again. Real simple. We put her on an SSRI, which are better anxiety treating meds probably than depressive meds, by the way, and put a Klonopin in her pocket. And we talked to her supervisor and said she may have to leave. If she feels a panic attack going up, she may have to leave. Take a Klonopin. She never had another one. She never took another Klonopin. But it was the fear of the panic attack. They are very, very dramatic and have been added to our list of what makes people suicide. That goes with schizophrenia, substance abuse, depression. Panic disorder has gotten in there now. They're terrifying. And people will disappear agoraphobia to their home. So there's panic attack. I'm putting these anxiety disorders in little packages. There's panic attack, there's PTSD, and there's OCD. OCD is probably the most underdiagnosed disorder in child and adolescent psychiatry. What I love about OCD is that it's treatable. If I can find it, see it, know it, it's treatable. People don't come forth and tell you they have OCD. They don't tell you that they have to count to 17 and stand every time a man walks in the room. They don't tell you things like that. They don't tell you that they have to watch a clock and make sure they never miss when the hour turns. OCD started in the Catholic Church, recognized it a long time ago. And they called it, what the hell did they call it? Anyway, it was somebody that came back over and over to confession. They had to come 65 times, not 22. But they had to come 65 times, and the priest began to say, there's something odd about this. They keep coming back, asking for forgiveness, Well, it's OCD. And let me tell you what else is OCD. Hypochondria is OCD. Oh, it was scrupulousness, the Catholic Church called it. Scrupulousness. Over-scrupulousness. They had an exorcism for it. Oh, that I had an exorcism for it. I have done one exorcism in my life, by the way, and it worked. I had a kid that I wanted to come to our medical school, and he said, it's between you and Chicago. This was the best candidate that year. He said, it's between you and Chicago. I said, hold still, and I pushed his head back and said, big on Chicago. And he came to our school because he called his dad, and his dad said, go where that man is, he's scary. You need to be close to him so we can keep an eye on him. Damn thing worked. It wore me out. Exorcisms they'll wear you out. But what does work with OCD is SSRIs. They really work in high doses. High doses. Obsessiveness requires a higher dose of SSRI. You are not going to get obsessiveness with 20 equivalent of Prozac. You may get the 60 or 80 equivalent of Prozac. Now, I'll tell you what else works in OCD is therapy, but people aren't available to do this cognitive behavioral therapy that's worked out beautifully without medications on board. So I begin with medications and then involve them in cognitive behavioral therapy, and they get really, really better. They get a lot better. If you've got a blood phobia, you can't just touch blood and get over it. You can't look at pictures of blood and then hierarchically go up to touching blood and get over it. But if you've got medications on board, you can do that. If you've got a horror of the highway, you can't just get on I-95 and get over it. But with medications on board, you can begin driving down your driveway and then drive down a bigger road, true story, and then drive down a bigger road with a friend in the car, and ultimately you can get on I-95 because you did the cognitive behavioral therapy, but medications on board to begin with. So OCD is real treatable. Most people aren't going to tell you they got it because it's weird and it feels crazy. And it's very... it feels bad. People hate it. Unlike, remember, the obsessive personality, which they love, neatness. They hate it. Just to touch on PMS or PMDD or whatever we're calling it, I think, I thought it was some confrontation about women to medicalize PMS, to make it a disorder. I think occasionally it may be a disorder, but it's also part of a normal cycle in a lot of women. And I thought Prozac probably had the biggest hand in it when they lost their patent and they went to Seraphim. Do you know Seraphim? It's Prozac. It's fluoxetine. And it was packaged in a different way, and they had 33 million hits early on because they'd lost their patent. And they were really medicalizing PMDD. My boss, who is probably doing the most work in the country in women's mental health, believes that PMDD might be more prevalent in people that have had a history of abuse. And he's got lots of reasoning behind, he's got lots of graphs about the hormonal milieu that make him say, watch out for people that have been abused, that have severe, at least explore that history, PMDD. One of the things we've done in Chapel Hill in taking care of women is, I've not been a part of this, but we have a perinatal unit for postpartum depression. That is, I'm a woman, I've got postpartum depression, I can bring my baby and come in the hospital. We did this absurd thing. We snatched depressed postpartum women, put them in the hospital and separated from their baby, which gets in the way of all those wonderful things that happen with the mom and the child. And so we got 4 beds, and we can swing it into 6 or 8 beds. And if you got a depressed postpartum woman, look for something like that. I think it's going to be on a slide in a minute, so I'll wait until I get there just to talk about postpartum depression. This is clearly jumping around at things I think I would like to hear. Benzos. 1957, maybe Librium. Roche got hold of it. Valium, 6 years later. Boom. Way, way overused. Then came the period of, don't use benzos. Now we're back to, I think, a fairly reasonable place with benzodiazepines. Pick one that you like. Klonopin, Ativan. Xanax is bad. Xanax has a short half-life. People like it too much. And if you've been to Paris, it's hard to not. Xanax, people who are taking Xanax have a hard time taking Klonopin. I like these medications. Let me tell you what they don't help in. And we'll talk about sleep. I've got lots of things I'll do before benzos for sleep. Benzos are no good. Recent data last month in anything that looks like PTSD. They're just no good. They blunt all sorts of things they shouldn't be blunting, and people with PTSD do not get better on benzodiazepines. Are they addictive? Yes. Have I had anybody that wasn't an addict get addicted to benzos? Maybe 1 or 2. Do I have people chronically on a small dose of long-acting benzo? I do. I have a woman that I've got no qualms. She has the most functioning in her life if she is taking she got 0.5 of Klonopin she carries around, and every day she takes 0.25 twice a day. It's not much. But I've been giving her this for a long time, and we don't do it. Her generalized anxiety just gets all over. We talk about it. We talk about her use of alcohol. We talk about her taking it the right way at the right time. We talk about her, of course, never getting it from anybody but me. But I'm comfortable treating her, and she's got a different life using benzodiazepines in this way. Dangerous in the elderly. Tony Lindsay, my geriatric psychiatrist, thinks they're almost contraindicated in the elderly. 2 reasons: cognitive blunting and falling. They will really cause cognitive blunting and eventually something that looks like delirium. So they're not good in the elderly. I'd almost say stay away from them. My wife has an uncle that is an Episcopal priest, lawyer. He took benzodiazepines for a long time. Checked into the hospital with GI something. He had this real quiet confusion that nobody was picking up on. I went by to see him. He invited me for lunch. He said he has lunch had just come. Would I sit with him and eat lunch? And I said, well, Cynthia sends her best. Please, Cynthia, send my best back to Cynthia. How is she? We finished, and I said, anything I can do or answer for you? He said, you can tell me who the hell you are. He was totally delirious on benzos, small doses over a long period of time. So watch out for them in the elderly, probably contraindicated in the elderly. Xanax I don't like. I think we underuse benzos and overuse. I have a lot of people carrying a Klonopin around in their pocket that I know that they're probably not going to take it. But they got a Klonopin in their pocket. I have a woman that froze on the big bridge here coming to Charleston. She froze, stopped, pulled over, had her panic attack, and she could drive over it backwards now. She's on Zoloft, and she's got Klonopin in her pocket. You save me a lot of trouble if you say in the beginning, now this is particularly in-house, in the hospital, if you say, look, I can't imagine having an illness like yours that doesn't have an emotional component. So that you don't have to get to the end and say, I'll be damned if I can figure this out. I'm going to call a psychiatrist. Well, I'm screwed. So is the patient. from the beginning, I can't imagine an illness like you have that doesn't have an emotional component. So let's keep that in mind all along. Just establish from the get-go that our patients that have these disorders we treat have an emotional component. When we go to a consult in child psychiatry in the hospital, the first question we ask is, what were you told about why we were coming here? My doctor said he couldn't figure it out, so he figured I must be crazy. I'm a hypochondria advocate. I'm no stranger to hypochondria. In my medical school days, particularly, I got quite a few things. I've actually, amazingly, had Lou Gehrig's disease twice. Yeah, amazing, and recovered both times. And if you know the baseball, if you have any baseball history, you'll understand that my neurologist said, this one's way out there. My neurologist said, look, let me just examine you. This was 10 years ago. I said, no, I've got it. I've got Lou Gehrig's. I'm out of here. Just tell me how it's going to go, what the process is going to be. He said, why don't I just examine you? He did. And he said, you don't have Lou Gehrig's disease. And I said, hang on. I feel like luckiest man in the whole world. If you get it, it's funny as hell. If you don't, I'm sorry. It was Lou Gehrig at Yankee Stadium. And that was and my neurologist said not to come back. He said he'd rather not see me again. I thought it was amazingly clever. Had I planned it? Yeah, if he told me no, yeah, I'd planned it. It wasn't improvised. Hypochondria is the bane of the existence of what we do. It is OCD. If OCD is tell me that I haven't sinned against anybody today, or my little girl that said every night her parents had to answer her 55 times that she had done no wrong to anybody that day. Tell me if I've done wrong to anybody today. It's OCD. It takes all sorts of, it's way beyond germs now. OCD has become very sophisticated. And it's way beyond germs, and it's way beyond, but hypochondria is OCD. Tell me I'm okay. Okay, you did good, thank you. Will you tell me I'm okay again? Okay, you did. Well, could you get that test one more? Just tell me one more time I'm okay. It's OCD that plays out in the doctor's office. I said earlier it's turbocharged OCD because it really gets its own life. And the more I do it, the more I do it. So I need to break that cycle with my patients. A take-home in psychiatry is it ain't good for your brain to be crazy. It ain't good for it to be depressed nor anxious, because the more it is, which I think is the best reason to treat like depression in kids. The more I do these things, they get entrenched, and particularly hypochondria, OCD things, they get a life of their own. And cognitive behavioral therapy in OCD is just don't do it. It's done in a much more sophisticated way, but that's cognitive behavioral therapy in OCD. Don't quit. You mustn't do that. It's not good for your brain. It's done professionally in a way with medications on board, but that's the essence of it. You got to quit doing it, because if you don't quit doing it, you're going to keep doing it, and you're going to do it more and more. Fake it till you make it. Yeah, and that's what you do, but that's the bottom line, is all what we're headed towards with OCD. Crippling disorder. It's just crippling. People get so sick and it feels so bad to them, and they can't stop. So maybe this will give you a different look at your hypochondriac. So, do you have any? I'm an adolescent psychiatrist. Do you have any guns in the house? Because we got Jimmy here. He's 15. He's sort of suicidal. Yeah, we got guns, but he doesn't know where they are. He knows where everything is. What do you think Jimmy does when you're away on a trip? He goes through your drawers. That's what he does. Jimmy knows where everything is. Please don't tell me he doesn't know where they are. Please don't tell me they're locked. Get the guns out of the house. You cut in one half suicides by teenagers. One half. Because I'm verbal, I'm a teenager, and I'm impulsive. So Jenny broke up with me. I think I'll just shoot myself. I'm also a magical thinker. I might be back tomorrow. And boy, that'll show them. If I don't have the damn gun, I don't do it. Get the guns out of the house. A question asked for everybody. I don't quite understand guns in the house. There are lots of ways that adolescents particularly kill themselves. One of my questions is, are you driving safely? And boy, I'm ready to take the car away from a kid that's had a moving vehicle accident that's depressed. I'm ready to take the car away. Take it away. Let's get them well. There's lots of ways to kill yourself. Driving here, Officer Doyle of the South Carolina force stopped me, and he said, and I believed him, that I was speeding. Officer Doyle said, he pulled me up on the computer, he said, you've got a fine driving record. I said, thank you, as he wrote the ticket. I thought I was off. He said, boy, you've got a fine driving record, as he wrote the ticket. Officer Doyle. Huh? Yeah, when he gets depressed. I said, I hope you don't get sad, officer. I thanked him. I love the Highway Patrol. I did. I said, you guys do great work. You don't bully people. You do great work. Thank you. As he wrote the ticket. My father used to get a ticket. My father was a man of few words. He had a 7th grade education, and he probably spoke, I would say 30 words a year. Maybe in a big year, 60, when you're really clicking. Story has nothing to do with anything. Ted Williams was my hero. Ted Williams played baseball for the Boston Red Sox. Ted Williams was a jerk. Ted Williams was coming through my hometown of Raleigh, North Carolina. I knew he was going to be downtown at the hotel. I was 11. I got my dad, who didn't quite believe people should get paid $100,000 to play ball. And for him, ball was all ball. Basketball, baseball, ball. He was a plumber and heater, ball. We went down to the hotel, the elevator door opened. Out walked Ted Williams. Well, he signed the ball. I've got the ball. My father had 2 questions for people, men. The first question was, what line of work are you in? The second question was, have you accepted Jesus Christ as your personal Savior? So I had my dad coming over, and I thought, woohoo! Woohoo! We're in trouble. And he said, hey, Mr. Williams, I'm Brian Bashford. And Ted Williams says, it's nice to meet you, Mr. Bashford. My father said, what line of work are you in? He said, I play ball. My dad said, interesting, boy plays ball. What line of work are you in? But he didn't ask the second one. I was so grateful. Because I had a strong feeling the answer was no to the second one. I've got the baseball. He never said anything about it. He just, that's what he did. They were 10 of his words that year. Nobody in the history of the universe has killed themselves because you asked them if they were suicidal. That is not a dangerous question. It's a question people are surprised sometimes you don't ask. Data that 30-50% of people come see their primary care doc in the weeks before they suicide. I think they're there to see if somebody will ask them about it. There are categories that you need to ask somebody. Depression, substance abuse, divorce, now we've added panic, and psychosis. And then all the other things you know, like loss of work, loss of self-esteem, shame. Shame and humiliation probably drive more people to suicide than most. Are there ways to do it? Yeah, it's hierarchical. You don't say, are you going to kill yourself today? I know things are kind of very rocky for you, or you're having such a hard time that you at times think about being better off not here. Yeah. Then pursue it to, do you have a plan? Have you done anything? And then you've got an obligation to do something. I think people will tell you most times. There's stories about, there's a story about an OBGYN resident that I go talk to the OBGYN training directors. He was in a hallway, training director asked him years ago, or how you doing? He said, I'm great, living the dream, and he shot himself 10 minutes later. So there are lots of stories about people not being forthcoming, but I think they're amazed when we don't ask them in that way. Are things bad enough that you've thought about not being here? And again, single car accidents, lots of ways to end your life. I'm about done, and then I'm going to take questions. I think I've got 2 more slides. And I'm doing this as I ask my faculty, please send me a bullet that you think I can take to these folks that are actually in the trenches seeing patients and what they need to be mindful of. This one, this one I send about, SINNED, send about many times. Damn it, why didn't I ask people that came in over and over with GI and GYN complaints that were diffuse, why I didn't ask them in the most understanding and careful way about how they were being treated at home. Not necessarily being hit, but marginalized. Looking back, I know lots of patients now that were marginalized. They didn't have a life of their own. Their husband ran the whole show, and they didn't have any kind of life of their own. And I just didn't ask those things, but they would present over and over. My GI, Doug Grossman, says he thinks of the gut as the other brain. He said it's, there's this brain and then there's that other brain, and it's the one that acts up. We've all had it. We've all taken a test and not felt good before the test. So over and over, and I think you're going to have the next talk is going to be about intimate partner violence, but there's ways that people tell us that's going on. I'm going to end up just talking about a couple of bullets about our friends SSRIs, and we have got to do better. This is not the end all. This is not the answer. We're at with this very rigorous treatment. 2/3 of people we take to remission, but this is rigorous. This is down to doing some really tricky things. With our tools, we get 50% of people to remission, and you're the ones that do it. I don't see somebody that walks off the street with depression. You're the ones that diagnose it. You're the ones that treat it. I live in Chapel Hill, where the majority of adolescents that I see have a parent. Between their parents, they have 2 MDs and a couple of PhDs and got an MBA we got on the side. Went to divinity school for a couple of years. They got all these achieving parents. So I get parents bring adolescents in saying, basically in a very sophisticated way, can you make him smarter, please? I'd like very much for him to be smarter. The worst thing you can tell a family in Chapel Hill about their child is, your kid is wonderful, wonderful. Average IQ. You could have said leukemia. Average IQ, oh my God. Well, wonderful. What would we do with an average IQ? So can you put him on SSRIs because he's not functioning the way we would want him to function? Well, you can define depression and you can define anxiety, and adolescents respond to these medications. You got to make some predictions with them. No adolescent has ever come back and said, Dr. Bashford, I've been taking Prozac now for 3 weeks, and I'm disorgasmic. That'd be a new one, wouldn't it? It doesn't happen. Drop the Prozac in the trash can. I know you didn't tell me, but I'm experiencing disorgasmia and some libido issues. No, you got to predict it, and you got to say, look, this may happen, and when it does, we can change medicine, decrease dose, but we can punch on. I just need to know. Early in the Prozac days, I called the number one honcho, the big kahuna at Prozac, and I said, look, I'm an old gynecologist. I was a young gynecologist, and I think I'm seeing some women with sexual dysfunction. He said, ridiculous. Men, maybe. That's not but 30% or so. If it's libido, watch out and make sure that wasn't part of the depression that you put them on the medicine in the first place. And if it's not, and it's libido, you're probably not going to catch up with it. Libido's hard. You don't gain tolerance to libido changes. Dysorgasmia, you do. So stay with it. Stay with SSRI if they tolerate it through that, but not libido. I'd be pretty quick to switch medications if it's libido. Remembering anything that smacks of obsessive, dose up, up, up. Anything that smacks of panic goes down, down, down. Nobody has any idea why 20 milligrams of Prozac is the right amount of medication. Nobody knows, but I've got people on 5 milligrams that have panic-like symptoms, and I've got people on 80 milligrams that have severe OCD. So you pick your drug. I don't care which one. They're all equally effective. Venlafaxine, Effexor, is a little bit nastier. It's also a second line if you're not getting it in this STAR-D. With your first one, venlafaxine is a good medication. It is really nasty to come off of. Electric feelings people get, and they're horrible. But it's good medication. Can people overdose on these? No. Can they overdose on benzos? No. Benzos and alcohol, maybe. Benzos are not very lethal. I had this wonderful kid that so much wanted to be a part of the crowd at Chapel Hill High School that he came. I put him on Prozac, and he just wanted to be. He was just a geek. He was a geek. He was great. He said, Dr. Bashard, I thought I needed to tell you last night I did a couple of Prozac. I said, God, I said, bless you. He just wanted me to know he was doing some extreme. I said, good. I did a couple of Prozac, like you've done heroin. I said, don't. That's what I have to say, and I've got 5 minutes to take up any of these topics or talk about anything that you might want to talk about.
I have a lot of women who are on medication, of course, prior to pregnancy.
Say that again.
I have a number of patients who are on SSRIs prior to pregnancy.
Yeah.
Then they want to come off.
Yeah. Okay.
I don't know how to.
Okay. All right. In the New York Times a month ago, there's an article that says, are antidepressants safe in pregnancy? They are kind of saying maybe not. Here's the deal. There's several caveats. One, SSRIs are probably not very teratogenic. I mean, there's stuff about smaller babies, withdrawal. There was data about pulmonary hypertension at one time, but it's not true. The flip side is the question's never asked, Dr. Bashford, what would be the outcome for me not taking these medications? That was never asked. It's always asked, what's the danger of these medications? There's some pretty good literature about not taking these medications being very detrimental, both physically and certainly emotionally, to the mom. If she's had a significant depression over a long period of time and gets very sick off medications and has been suicidal, or, yes, no question. If she is just going to be so anxious about it, and intrapartum and postpartum depression are anxiety-laden, they really are. They're much more different than the depression we get. If she's going to be so anxious about it and this is where I want the husband in there or the partner in there hearing it too, then I might take off for the first trimester. I'm going to have a hard time catching up. It's harder to catch up. But if that's just going to make her nuts, I might do it. I think they're safe. If the indications for the SSRIs were good to begin with, I think they're safe in pregnancy. And there's no question about breastfeeding all across breast milk. And then I'm going to warn her if she's had depression, for sure at the end to be on antidepressants, because postpartum depression is crippling for her and baby. So I lean towards, yeah, take them.
Just a follow-up. If you've had somebody who's not been on medication before, you put her on medication because you're treating postpartum depression, what would you suggest as the course of treatment, length of time?
Oh, I do everything for a year. That's my time. A year. And a postpartum depression, in 1860, if you and I got depressed, 60% of us would get better in a year on our own. We'd have had a miserable year, and we'd have been at risk for hurting ourselves. But it is a cyclical disorder. So I'm a year, and I do that in the beginning and don't do it at any stressful time. Postpartum depression is tricky business. It looks more like OCD than depression. The mom that says, and the key word for me is anhedonia, are you enjoying your baby at all? No. That's postpartum depression. I don't care about sleep or anything else. Anhedonia. It gets an OCD flavor to it. I get up every night and look at my baby 27 times. I've got nightmares about suffocating my baby. They're not going to do it. It's OCD-like. So you may need more than just in a postpartum depression than SSRIs. You may need a little smidgen of Risperdal. And we were talking about sleep. Treat sleep first. I tell my psychiatry residents, don't start treating anything that treats sleep. And we got lots of tricks. People using trazodone in this world. Yeah, really good. Trazodone's a great sleep agent. It came on the market as a good antidepressant, but it made people too sleepy, so we use 50 milligrams, and it's a good sleep agent. Titrate it to feeling hungover. But I keep treating. I'm a child psychiatrist. I also want attachment to occur. But my one question is anhedonia. If they're not enjoying that baby at all, then that's postpartum depression till proven otherwise.
After SSRIs, once or twice or 3 times even for depressed and anxious patients, what do you go to after that?
Psychiatrist. I do, because I want.
Usually 4 months or 5 months, so I'm kind of stuck.
Yeah, I don't know what's going on after 3 treatments of depression. No better. They got better or didn't get better.
Tolerate the medicine, whatever the story might be.
Yeah, I'm very serious, and I go to psychiatrists. I make damn sure they don't have. You're the doc, but make sure they don't have something else going on. And then this personality disorder, you're not going to make it better with SSRIs. Therapy may well be a part, but I would get some distance, get my friendly psychiatrist to give me one. I do this a lot. Give me one consult. Help me think about another set of ears and eyes where we are with this patient.
You probably just answered this question a minute ago, but I recently read that Prozac was also lumped in with Paxil as far as not to use in pregnancy because of cardiac malformations. Have you read that or heard that?
Yeah, I mean, I've seen that, but I don't think it's substantial. Prozac got beeped for pulmonary hypertension, cardiac malformations, which maybe I think at one time there was maybe this tiny little increase in a very rare cardiac malformation. You can get past that by not treating the first 14 weeks. But that never stuck on me. The only thing that ever stuck on me was the withdrawal. I believe that. I believe these babies are floppy and kind of difficult in the nursery that have been on medications. What did it say? What was the... it was a very small, it's like the pulmonary hypertension, a very small increase in a very small number that have the disorder. It's risk-benefit. Mom's been suicidal. She can't take care of herself if she's not taking SSRIs. She needs to be taking them.
Dr. Vosges, do you think we demonize psychiatric
Yeah.
I know the patients demonize it.
Yeah.
They don't want to label that they're depressed or they're anxious a lot of times. But when I was dealing with people, I'd look at them and say, look, I can't fix lung cancer but 15% of the time. There's nothing wrong with being depressed. There's a lot wrong with not fixing it.
Yeah.
You know, at least we got drugs we can try, and I'll give you some samples. But, you know, it at least gets the conversation going about the fact that when you eyeball the person and you feel sad, you know damn well they're depressed, but they're totally denying it. And once you cut through the crap, I guess it is, about let's get rid of this stuff and make it an okay thing,
Yeah.
then some people will open up and be more willing to at least try something to get better.
That's where you may need another set of ears, another husband, partner, mom, somebody else hearing you. I think what we've done that is wrong, we've over-medicalized so many things in psychiatry. We're hammers looking for nails. That's what we do. I'm out there looking for depression. I may miss the underlying things that have caused a person to be that way. I think I can bring people to taking medications if they've really got a depression. I got to establish a relationship. I just have a policy of not writing a prescription on the first visit. I'm just not going to do it unless it's just so obvious. I just don't write prescriptions. I want to get some relationship, come back, and let's talk about taking meds. And then when I get meds going, I'm sending them back to you.
A lot of women are coming already with diagnosis of bipolar.
Oh, that got so. That's just psychiatry has this wonderful. We do this. We won a Nobel Prize for frontal lobotomy. We did. Okay. Then we had a period of time where all God's children on this earth have bipolar. And it was on the front of Time magazine. And people were just diagnosed. It's not so. It is so many presentations of different things with erratic behaviors. If you've got somebody that has just bought 4 red Corvettes, one for everybody in the family, hadn't slept in weeks, has been writing children's poetry at night, even though they're not a poet, and their mom was on lithium, I'm probably going to put them on lithium. This is my person that stayed up really for nights writing children's poetry. Have you ever written a poem before? No. But she stayed up all night writing. It was horrible. She brought them to me. They were horrible. But it is a spectrum disorder, and over here the real deal bipolar, cycling, in trouble with sex, money, drugs, can't sleep, irritating the hell out of everybody, up higher. And then over here is this cyclothymia, that high, low, low, high, but it doesn't do that. It became the diagnosis in child psychiatry. We went there. We got new ones on the horizon. I mentioned gender dysphoria is on the horizon, and we'll give that one a few years. We will. Somebody went to school, they told me, and they were asked, an 8-year-old, what pronoun they would like to be called by 2 weeks ago. Now, I'm a simple psychiatrist. What? The little girl was confused. She came home and asked her mom, what does that mean? So Mom asked me what to do, and I said, find another damn school. Yeah.
I understand what you said about not using Prozac in the first trimester, but I understood people are on meds in the first and second trimester. It's best to try to wean them at least for the third trimester.
Well, is that the why? And why? I don't think so. Not if they've been depressed. The baby may have either withdrawal. I don't know what they have, but they're floppy babies. They don't lose them in the nursery. They take good care of them.
Do you have a recommendation of the safest one to use?
Oh yeah. Zoloft has got the record. The guy in Atlanta, Zoloft has got the record. Yeah, that's if you want to be on the safe side of safe. The guy's done all the literature and comes up with that.
Any other questions?
So I decided to be a psychiatrist. I've told you a little bit of it. I'm nearly done, Ryan. I called my own personal mother, who believed that everything I did was right. See, that's why I've got this personality disorder I've got. Because I brought home a note in 3rd grade and it said, if Robert would just be quiet, I think he could learn. And my mother said not to worry, she's a new teacher. So I called my mother and I said, Mom, I'm going to give up this OB and go back and I'll do a psychiatry residency. She said, she called me Sugar. She said, Sugar, you know I support everything you do, but have you met any of them? Yep, Mom, I have. Well, thank you. It was fun. I hope you got something.